Yes. Okay. This patient has this patient has ankle injury with diffuse swelling and inability to bear weight. Initial imaging with X-ray is appropriate, although CT scan may be needed to fully visualize a fracture. CT scan shows a distal tibial epiphyseal fracture, distal tibial epiphysis fracture, and physeal fracture growth plate. So epiphyseal fracture, physeal fracture are suggested by plate widening. Growth plate widening. This combination of feature is known as Salter-Harris type. Salter-Harris type fracture. Look at the classification of the Salter-Harris type. Type 1 fracture across the growth plate. Type 2 growth plate plus metaphysis. Type 3 growth plate plus epiphysis. Type 4 growth plate plus metaphysis plus epiphysis. And growth type 5 is compression fracture of the growth plate. So it is metaphyseal and epiphyseal. Okay. Salter Harris metaphysis. Okay. This mm, distal tibial growth plate typically closes around age 14. This distal tibial growth plate closes around age 14 and age 12 in girls, and fracture involving maturing, particularly fused physis, Salter-Harris type 3 and 4 carry an increased risk of long-term complication. In particular, injury to the growth plate can cause growth arrest, can lead to persistent limb length discrepancy. Other complications include formation of physeal bars, bony bridges across the plate, premature osteoarthritis, and decreased range of motion. Okay, traumatic foot drop is typically caused by the injury of the common peroneal nerve, where it wraps around the lateral neck of the proximal fibula. Distal fractures of the tibia or fibula would not cause foot drop. Okay. Is it PMR? Polymyalgia always usually not comes with headache, not always comes with headache. And Low dose prednisolone therapy is improve heart symptom. So low dose prednisolone is given in PMR, so we do not need to do any tests. Temporal lobe biopsy for temporal arteries, giant arteries, where high dose glucocorticoid is used. Okay. Okay. So this patient has polymyalgia rheumatica PMR, an inflammatory disorder characterized by the following feature: acute onset of symptoms, acute onset of symptoms more than 2 weeks, age more than 50. Okay, acute onset of symptoms, uh, 2 weeks and age more than 50. Prolonged morning stiffness and getting stiffness with activity. Sorry, a prolonged morning stiffness and getting stiffness with inactivity in proximal joints, and markedly elevated inflammatory markers, EF or CRP. PMR involves periarticular structure vasa tendon, but the muscle tissue itself is unaffected and remains histologically normal. Therefore, objective muscle strength is preserved as in this patient although the range of motion can be limited due to pain and stiffness. PMR involves periarticular structure. PMR involves periarticular structure, bursa tendon, but the muscle tissue itself is unaffected, remains histologically normal. Therefore, can you hear me? Okay, maybe. Okay. And therefore, objective muscle strength is preserved as seen in this patient. Although range of motion can be limited due to pain and stiffness, there is no specific diagnostic test for PMR. Treatment with low-dose glucocorticoid therapy, prednisolone 20 mg, is usually initiated in patients with characteristic presentation. Although rapid response supports the diagnosis, whereas lack of improvement should prompt consideration of other diagnosis. These patients' presentation and rapid symptom improvement with prednisolone are sufficient to establish the diagnosis of the PMR, and no additional testing is required. Okay, I can hear you. Hello, hello, hello. Yes, okay. Give me 1 minute. I haven't answered the question. Okay. It is DMD, Duchenne muscular dystrophy. First, the box. Look at the box. Duchenne muscular dystrophy, there is mutation in the dystrophin gene. Mutation in dystrophin gene on X chromosome. Absent absent dystrophin in muscle cytoskeleton. Absent dystrophin in muscle cytoskeleton, and there is muscle atrophy. A replacement with connective tissue or fat. Mm, Clinical findings: proximal muscle weakness, boys 2 to 3, delayed motor milestone, toe walking, waddling gait, Goar sign, calf pseudohypertrophy, scoliosis, lumbar lordosis, dilated cardiomyopathy, and there is restrictive lung disease. Evaluation: increased CK, genetic analysis is a diagnostic. Management: glucocorticoid, serial ECG, echocardiogram, pulmonary function test. Prognosis: wheelchair type, wheelchair use, typical by adolescent, and shortened lifespan age 20 to 30 from respiratory failure or heart failure. Okay, okay, now explanation. The toddler boy with a history of delayed walking has a high thigh atrophy, calf enlargement, and in elevated CK level. Elevated CK level findings concerning of Duchenne muscular dystrophy. DMD is caused by absent dystrophin, which leads to progressive muscle deterioration starting in the proximal lower extremity. Patient may toe walk to compensate for quadriceps weakness, and cramping or pain is common with muscle atrophy. Replacement of muscle with fibrofatty tissue. Replacement of muscle with fibrofatty tissue leads to the characteristics finding of calf pseudohypertrophy as seen in this patient. Over time, cardiac muscle and skeletal muscle of the respiratory system are also affected, and patients are at risk for cardiopulmonary complication. There may be dilated cardiomyopathy, there may be restricted lung disease. Dilated cardiomyopathy, restricted lung disease. Dilated cardiomyopathy, absent dystrophin in the cardiac muscle. Absent dystrophin in the cardiac muscle causes atrophy and fibrosis of the left ventricle, resulting in arrhythmia and left-sided heart failure. Restrictive lung disease, decreased pulmonary function due to respiratory muscle fatigue, can lead to atelectasis, pneumonia, and respiratory failure. Scoliosis contributes to restrictive pulmonary function and is common in DMD due to weakening of weakening and imbalance of paraspinal muscle due to weakening and imbalance of paraspinal muscle, as well as body positioning with wheelchair use, typically by adolescents. Because early detection and treatment complication can prolong the survival, ECG and non-invasive imaging, echocardiogram, cardiac MRI are indicated at diagnosis. Pulmonary function testing begins around age 5 to 6 when children can comply with testing. Treatment involves glucocorticoid to slow the disease progression and cardiac ACE inhibitor and respiratory support. Okay, next. Is it transient synovitis? Sorry. Okay. Difference between transient synovitis and septic arthritis first. Clinical presentation, there is transient synovitis is well appearing afebrile or low grade fever able to bear weight, and septic arthritis is ill appearing febrile and non weight bearing. Ill appearing febrile and non weight bearing. Diagnosis: normal or mildly elevated WBC, normal or mildly elevated WBC, ESR, CRP, unilateral or bilateral joint effusion or ultrasound, and diagnosis of the exclusion. And septic arthritis, moderately elevated WBC, ESR, CRP, positive blood culture, unilateral joint effusion or ultrasound, and synovial fluid WBC more than 50,000. And transient synovitis treatment is conservative, and septic arthritis joint drainage and antibiotic. Okay, these are the common cause of atraumatic hip pain, limp in children. Atraumatic hip pain or limp in children is transient synovitis, a self-limiting inflammatory disorder, often preceded by viral illness. Transient synovitis must be distinguished from septic arthritis, a potentially life-threatening infection requiring emergency treatment, IV antibiotic. Transient synovitis patient typically presents children 3 to 8 and have who are afebrile who have low grade fever. Patients have pain and limited mobility. Patients have pain and limited mobility of the affected joint but can usually bear weight. Leukocyte count and inflammatory markers CSR, CRP are normal or slightly elevated. ESR, CRP are normal or slightly elevated. In contrast, septic arthritis findings include high fever, inability to ambulate, severe pain, abnormal lab evaluation, leukocytosis, elevated ESR, CRP. Sometimes patients can have overlapping clinical features as in this child, overlapping clinical feature as in this child with low grade fever, mildly elevated ESR, but with severe pain, inability to ambulate, and leukocytosis with neutrophil predominance, suggestive of septic arthritis. When the diagnosis is unclear, bilateral hip ultrasound is performed. Bilateral hip ultrasound is mm, when uh, when diagnosis is unclear. Bilateral hip ultrasound is performed. Joint effusion in septic arthritis. Joint effusion in septic arthritis is unilateral, whereas 25% with joint transient synovitis have bilateral hip effusion even with unilateral symptoms. Even if hip ultrasound shows unilateral effusion, arthrosynthesis is required to evaluate for septic arthritis. Okay. Is it rheumatoid arthritis? Okay. This patient's presentation is consistent with moderate to severe RA. RA is a chronic systemic inflammatory disorder with progressive erosion of the bone and cartilage and significant joint destruction and deformity. Patients typically presents with joint findings, pain, stiffness, swelling, morning stiffness, involvement of proximal interphalangeal and metacarpophalangeal, and radiograph evidence of erosion and periarticular osteopenia. Treatment goals in RA to induce and maintain early remission, control synovitis, prevent progression of joint damage. So look at the box. Rheumatoid arthritis, methotrexate. After giving methotrexate, if persistent symptoms for more than 6 months, then parallel therapy, like add another non-biologic agent like sulfasalazine or hydroxychloroquine. Or you can step up therapy, add biologic agent, TNF alpha inhibitor, infliximab, golimumab. If parallel therapy does not work, then step up therapy. If inadequate response, switch to alternate TNF alpha inhibitor and continue methotrexate. Okay, all patients diagnosed with RA should be started disease-modifying anti-rheumatic drug as soon as joint damage joint damage begins early in the course. NSAIDs and COX-2 inhibitors, celecoxib, are adjunctive therapies for celecoxib. Adjunctive therapies for symptomatic relief but does not reduce the disease progression. Glucocorticoid can relieve symptoms and short-term radiographic progression but are also not effective in preventing eventual joint destruction. They can result in generalized bone loss, osteoporosis. TMRDS include non-biologic agent methotrexate, hydroxychloroquine, sulfasalazine, leflunomide, azathioprine, and biologic agent etanercept, infliximab, adalimumab, tocilizumab, rituximab. MTX is preferred initial DMARS in patients with moderately or to severe acute RA due to its efficacy and long-term safety profile. Patients should be tested for hepatitis B and C before starting the therapy. MTX should not be used in patients who are pregnant and are planning to become pregnant in the near future. Those with severe renal insufficiency, liver disease, and excessive alcohol intake. Patients who do not respond after 6 months may require biologic DMARS like TNF alpha inhibitor, etanercept, infliximab as step-up therapy. Okay, According to labs, pleural fluid protein by serum protein, pleural fluid LDH by serum LDH. So pleural fluid protein by serum protein is more than Light's criteria. Yes. And yes, it is not silly. And sarcoidosis have high calcium. Sarcoidosis, he has lung issue, but it is pleural effusion, moderate right-sided pleural effusion, not bilateral hilar lymphadenopathy. And he has joint pain, and he is on a joint pain. Look, yes, RA-ILD can happen. Okay, this patient with pleuritic pain has pleural effusion, high pleural fluid by serum protein 0.67, 4 by 6, and high LDH and high LDH ratio, like pleural fluid LDH by patient's LDH. Based on light criteria, these findings are consistent with exudative effusion, which usually results from an inflammatory disruption of vascular permeability. Several features of patient's presentation suggest rheumatoid arthritis as the underlying diagnosis. Rheumatoid diffusion, often marked by very low, less than 50 glucose, very low glucose, high LDH, very low glucose, high LDH. They may also have low pH resembling bacterial pyoemia. In general, effusions with very low glucose are most often RA. So effusions with very low glucose most often due to RA, empyema, malignancy, and TB. The patient has evidence of an inflammatory arthritis, joint swelling, tenderness, and morning stiffness. Her lung crackles on examination and increased interstitial marking on X-ray are consistent with ILD, which along pulmonary nodules and pulmonary manifestation of RA. Exudative pleural effusion are commonly extraarticular manifestations of RA, although they may have asymptomatic and usually resolve spontaneously. Okay, yes, okay. According to Light's criteria for exudative pleural effusion, pleural fluid protein by serum protein more than zero point 0.5, pleural fluid LDH by serum LDH more than 0.6, and pleural LDH More than two-third upper limit of the serum LDH. Pathophysiology is inflammatory disruption of vascular permeability. Common causes is infection, TB, pneumonia, malignancy, rheumatologic disease, RA, SLE, pulmonary embolism, pancreatitis, post-CABG. And transudative exudative criteria not met. Pathophysiology changes in hydrostatic or oncotic pressure. There may be heart failure, CCF, cirrhosis, nephrotic syndrome, and constrictive pericarditis. Okay, can you give me 5 minutes? I'm coming. Yeah. Okay. It is clubfoot. The fetus has bilateral congenital clubfoot. Talipus equinovarus, a deformity caused by abnormal development of the thallus bone. Abnormal development of the thallus bone. In most cases, the deformity is isolated without other structural abnormality. The etiology is likely multifactorial and may involve genetic factor, long-standing intrauterine mobility, oligohydramnios, and certain overlying chromosomal or neurovascular disorder. Spina bifida in a developing fetus, congenital clubfoot, the connective tissue and the musculature of the foot and distal cuff surrounding the talus bone do not fully develop. This leads to plantar flexed foot. This leads to plantar flexed foot with and adducted and internally rotated forefoot. Adducted and internally rotated forefoot. Congenital clubfoot is a fixed deformity which can be seen on imaging as an affected foot in the same plane as the tibia and the fibula, even with fetal movement, as in this patient. Initial management of congenital clubfoot is gentle manipulation and stretching with serial molding casts, ideally beginning in the neonatal period. Once an optimal position is achieved by casting, long-term bracing is typically required. Surgical correction is reserved for refractory cases or recurrence of and the recurrence of initial management is congenital gentle manipulation and stretching with serial molding casts, ideally beginning in the neonatal period. Once an optimal position is achieved by casting, long-term bracing is typically required. Surgical correction is reserved for refractory cases or recurrence of clubfoot after non-surgical treatment. If untreated, clubfoot leads to abnormal gait with weight bearing on the lateral aspects of the feet. Okay. Okay, these patients acute knee pain, warmth, erythema, restricted range of motion, and synovial fluid leukocyte count more than 50,000 indicate septic arteries. Most cases are caused by hematogenous dissemination of Staph aureus or other gram-positive organism and are adequately treated with vancomycin, a bactericidal antibiotic with activity primary against gram-positive cocci via inhibition of cell mm, However, however, patients occasionally have continued symptoms despite a few days of vancomycin treatment, which usually indicate infection with an organism not covered by vancomycin gram-negative bacteria. Therefore, patients generally require broadening of antimicrobial therapy to cover the gram-negative joint pathogen such as Kingella, a third-generation cephalosporin ceftriaxone, which has excellent activity against both gram-positive and gram-negative organisms, and some anaerobes would likely to be initiated while culture results are pending. Okay, okay. This infant with neck mass, ipsilateral head tilt, contralateral chin deviation, has congenital muscular torticollis. CMT is a postural deformity in which sternocleidomastoid muscle is tight and contracted, likely due to intrauterine crowding, breech positioning, as in this patient, multiple gestation and oligohydramnios. Associated conditions that are also related to prenatal positioning include developmental dysplasia of hip, metatarsal adductors, and clubfoot. CMT is uh, evident from birth but typically comes to but typically comes to medical attention at age 1 to 6 months, with a head preference to one side. When an infant lies between when an infant lies between when an infant lies down with head facing the preferred type, positional plagiocephaly often occurs. Okay. Often occurs, which entails flattening of the head on that side as well as anterior displacement of the ear and forehead ipsilateral to the flattening. Limited range of motion of the neck is also present on examination. Sternocleidomastoid thickening or a well circumscribed mass from muscle fibrosis may be palpable. Treatment strategies include positioning, increase tummy time, passive stretching, physical therapy, and missed or delayed diagnosis can be craniofacial asymmetry. Okay, yes. Craniosynostosis, premature closure of the cranial suture results in premature suture or premature closure of the cranial suture results in skeletal deformity but not anterior displacement of the ear and forehead. In addition, head tilt and neck mass would not be present. Okay, my mom is calling. I'm coming. 1 minute. Right hip is flexed, abducted, and externally rotated. Flexion and external rotation. Uh, the left. Is it DDH? Then it is transient synovitis. Then it is sickle cell bread crisis. It is septic arthritis. Septic arthritis in here leukocyte count is more than okay. Okay, so I'm wrong. So we are in the wrong direction. So septic arthritis, typhoria group B. Okay. The infant with fever, pain, with hip movement and leukocytosis. Fever, pain with hip movement and leukocytosis likely has septic arthritis. This joint infection this joint infection most commonly occurs in healthy children aged less than 4 via hematogenous spread of bacteria. Staph aureus is the most common cause. Staph aureus is the most common cause, but group B streptococcus and gram-negative bacilli, Klebsiella E. coli also commonly also occur frequently in infants aged less than 3 months. The presentation classically includes acute onset fever, monoarticular joint pain, inability to bear weight. Inpatient Inpatient symptoms may be non-specific, including fever, inconsolability, and poor feeding, as in these patients. Subtle signs of joint involvement, most commonly knee and hip, subtle signs of joint involvement, most commonly knee and hip in infants, include lack of movement of the affected site, pseudo-paralysis, and excessive fuzziness during diaper changes or repositioning, as seen in this patient. Infants often lie in the affected hip, flexed, abducted, and externally rotated to maximize the joint space and comfort. Physical examination may reveal pain with active and passive range of motion, as well as asymmetric swelling. Supportive findings include leukocytosis with neutrophilic predominance and elevated inflammatory marker C-reactive protein and elevated C-reactive protein and ESR. Management include joint aspiration and prompt initiation of the antibiotic. Okay. Is it DVT? Mm, there is sensory loss of fascia. Okay, it is compartment syndrome. Okay, so this patient has increasing pain and calf tenderness. This patient has increasing pain and calf tenderness after arterial injury. A presentation concerning for compartment syndrome. Compartment syndrome is due to elevated pressure within the fascial space, which prevents adequate perfusion of the tissues. It can be caused by trauma or prolonged compression of an extremity or by repercussion after revascularization of an acutely ischemic limb. Patients typically have severe pain that is worsened on passive range of motion. Neurologic manifestations include paresthesia and sensory or motor deficit, pulse deficit, and pallor due to arterial occlusion are uncommon. Compartment syndrome is a life-threatening condition. Have diagnosis require an high index suspicion. The diagnosis can be confirmed by measuring compartment pressure, needle manometry, a delta pressure, diastolic blood pressure minus compartment pressure, less or equal 30 millimeter of mercury, reflecting compromised perfusion pressure, a strongly suggestive compartment syndrome. However, in high-risk patients, those with limb revascularization, the diagnosis may be made on clinical ground alone. Management includes urgent fasciotomy and treatment, and time to fasciotomy is the most critical prognostic indicator. Okay, okay. Osteoporosis, which is characterized by low bone mass increases a patient's risk for fragility fracture. Fracture resulting from minimal trauma such as a fall from standing height. The risk of osteoporotic fracture is the greatest in postmenopausal women of advanced stage and those with low BMI. Excessive alcohol consumption and long-term glucocorticoid use, the smoking cessation, mm, the risk is also significantly increased in those with prior fragility fracture. Current smoking also raises the risk, although smoking cessation can stabilize bone density and may reduce fracture risk. Screening for osteoporosis with DEXA to measure BMD is recommended for all women at age 65 and for younger women who are at significantly increased osteoporotic fracture. These patients fractured a rib while coughing, low trauma fracture, so DEXA testing is warranted. Frax risk calculator can estimate the risk of fracture without DEXA results, but it is much more accurate if bone mineral density is entered. Intervention to Interventions to reduce the risk of fracture include weight-bearing exercise, adequate intake of calcium and vitamin D, and bisphosphonate therapy. Okay, a vegan diet, no intake of any food products of animal origin, including dairy, is associated with low bone density. However, it is not clear whether this is due to diet. This is due to diet itself or to an increased prevalence of or okay. However, it is not clear whether it is due to the diet itself or to an increased prevalence of low body weight in such patients. Current evidence does not show a significant risk of fragility fracture in person consuming a standard vegetarian diet who have not have low body weight, who do not have low body weight. Okay. Okay. It is systemic sclerosis, often termed as scleroderma, characterized by connective tissue thickening due to fibroblast dysfunction, and increased collagen and ground substance production. Cutaneous features include thickening of the skin that begins in acral sites, hands and feet with edema that transition to dermal sclerosis, sclerodactyly, and obliterating skin appendages, hair follicles, sweat glands. Vascular dysfunction, Raynaud's phenomenon, is is present in most patients. Extradermal manifestations are common, especially in those with more extensive skin involvement. Frequent complications include esophageal dysmotility, interstitial lung disease, and hypertension due to renal involvement. The diagnosis of the systemic sclerosis is based primarily on clinical manifestation and serologic marker. Antinuclear antibodies are present in almost all patients but not specific. Anti-topoisomerase 1 and anti-RNA polymerase 3 are less sensitive but more specific and are associated with extensive disease. Anticentromere antibody may be Anticentromere antibody may also be seen primarily in patients with limited disease. Sorry, medial joint line. Is it mm, medial knee pain is Pes-Ansernus bursitis. Pes-Ansernus syndrome. Pes-Ansernus. Uh, yes. Bursitis should have fever. She has low vitamin D level. Is it due to vitamin prior trauma? Okay, okay, it's atypical osteoarthritis secondary way. So, this patient most likely has osteoarthritis. Hello, can you hear me now? Hello, 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 hello. Can you hear me now? Okay, extremely sorry. I don't know what is going on. Okay, this patient most likely has osteoarthritis of the knee, presenting with monoarticular arthritis that is worse with joint loading during kneeling and negotiating stairs. Osteoarthritis is very common. Osteoarthritis is very common in patients with prior injury or surgery. Secondary osteoarthritis contributing factor including altered joint mechanics and both acute or chronic inflammation which can lead to altered expression of matrix metalloprotease and accelerated chondrocyte death. Osteoarthritis develops within 10 years in most patients with anterior cruciate ligament injury. The risk is increased whether or not the tear is surgically corrected. Other causes of secondary osteoarthritis include joint infection, inflammatory disorder, rheumatoid arthritis, congenital or acute bony deformities, and neuromuscular weakness. Okay, yes. Chronic hyperglycemia can accelerate the progression of osteoarthritis, likely due to glycosaminoglycans of components of articular cartilage. However, these patients' HbA1c is only slightly elevated and likely has little effect on his osteoarthritis risk. And vitamin D deficiency can lead to osteomalacia and manifestation with bone pain, muscle weakness, disorder growth, and increased risk of fracture. Subclinical deficiency is associated with osteoporosis. It does not cause monoarthritis of the knees. Okay. Is it degenerative disease osteoarthritis? Okay. Okay, this patient with slowly progressive pain relieved by rest and has degenerative joint disease osteoarthritis of the hip. Osteoarthritis is the common joint disorder and is characterized by progressive destruction of the articular cartilage. Predisposing factors include age more than 40, obesity, diabetes mellitus. Osteoarthritis most commonly affects the interphalangeal joints of the hands and the large weight bearing joints of the lower extremity. The pain on hip osteoarthritis he typically felt in the groin, button, and lateral hip. It can radiate to the it can radiate to the lower thigh and knee. Patients may have mild pain and brief stiffness with prolonged rest, but the worst pain typically the worst pain usually occurs with activity and weight bearing. Examination finding often decreased rotational range of motion, but synovitis, redness, warmth is absent. Common X-ray findings include loss of joint space, osteophyte formation, and subchondral sclerosis. Okay. Yes. Osteonecrosis is characterized by reduced perfusion of the femoral head and collapse, reduced perfusion of the femoral head and collapse of the periarticular bone like osteoarthritis. It can present with groin pain and reduced hip range of motion. However, most patients have nocturnal or waist pain, and almost all have a history of glucocorticoid use, sickle cell disease, or heavy alcohol use. Diabetes is not a significant risk factor. Next, probably it can cause bone destruction, rheumatoid arthritis. If we think that RA is an erosive disease, it can destroy our bones. Okay. This patient has chronic symmetric polyarthritis. Chronic symmetric polyarthritis consistent with rheumatoid arthritis. RA is a progressive inflammatory disorder. There is common in women. That is more common in women. It can occur at any age, although peak incidence is at 30 to 60. RA is characteristically associated with prolonged morning stiffness, and symptoms may be more noticeable in the dominant hand. The most commonly affected joint include the metacarpophalangeal joints, the metatarsophalangeal joints, and the proximal interphalangeal joints, wrists, and knees. Extra-articular manifestations are common in RA, especially in patients with positive serology rheumatoid factor, anti-citrulline peptide antibody, anti-CCP antibody, systemic feature weight loss, fatigue, anemia, and are frequently present. Rheumatoid nodule, firm, non-tender subcutaneous nodule may be seen at pressure points such as elbows, forearms. Other complications include pleural effusion, fibrotic or restrictive lung disease, coronary atherosclerosis, autoimmune exocrine dysfunction. Okay, yes. Inflammatory bowel disease is associated with both axial spondyloarthritis and peripheral arthritis. The peripheral arthritis can manifest as pauci-articular, self-limited pauci-articular arthritis, typically affecting the knee, a chronic polyarthritis that primarily affects the metacarpophalangeal joints. Although this second type may resemble RA, it is common and almost always follow onset of gastrointestinal symptoms. And the lumbar facet joints are commonly involved. Osteoarthritis, the lumbar spine is a common site for disc herniation and spinal stenosis. However, RA does not typically involve the thoracic, lumbar, and the sacral spine. Yes, yes. Look at the radius. There is slight fracture in the radius. It is torus or buccal fracture. Okay, forearm fracture are uncommon in children and most frequently involve the distal radius and ulna. Most frequently involve the distal radius and ulna after fall on outstretched and young children age less than 10 have young children age less than 10 have porous bone which allows for compression of the distal metaphyseal cortex after an injury. The result in buccal fracture, which is characterized by cortices and bending, buckling without breaking and becoming displaced, as typically occurs in complete fracture. For this reason, a buccal fracture is considered a stable and incomplete fracture. Buccal fracture present with pain and tenderness over the fracture site. Wrist range of motion Wrist range of motion may be intact or slightly limited. Impaired thumb movement due to radial injury and swelling is often absent. X-ray is required to confirm X-ray is required to confirm the diagnosis and exclude a green stick or complete fracture. Rather than a fracture line, a cortical bulge is visualized. Treatment involves pain and Treatment involves pain control and prevention of re-injury. Splint placement. Most buccal fracture heal within few weeks without complication. In children, avascular necrosis most commonly involves the hip leg curve birth disease and presence with chronic joint pain and decreased range of motion. X-ray findings with prolonged disease include bony fragmentation and sclerosis, bony fragmentation and sclerosis, a distal forearm fracture with a cortical bulge. A distal forearm fracture with a cortical bulge is most consistent with a buccal fracture. Okay. Maybe Takayasu. BP discrepancy happens in Takayasu. And pan pulmonary is spared. No pulmonary symptom though. Okay. In polyarteritis nodosa, there is no pulmonary symptom, and it is associated with hepatitis B. Okay. This patient with exertional, this patient with exertional arm pain, likely claudication, systemic symptom, left arm pulse deficit, likely left subclavian stenosis, has typical features of Takayasu arteritis, large vessel vasculitis that predominantly affects Asian women at age less than 40. It primarily involves the aorta and its branch is characterized by mononuclear infiltrates and granulomatous inflammation of the vascular media, leading to arterial wall thickening with stenosis, occlusion, or aneurysmal dilatation. Initial symptoms are non-specific fever, arthalgia, weight loss. As the disease progresses, vascular involvement with arteriocclusive manifestation. Vascular involvement with arteriocclusive manifestation claudication may develop, particularly in the upper extremity. Examination include blood pressure discrepancy, pulse deficit, blood pressure deficiency, pulse deficit, and ruin due to localized arterial stenosis. Patients commonly have elevated inflammatory markers, ESR, CRP, CT or MR angiography, the preferred diagnostic modality. and may reveal thickening of the large artery walls, narrowing of the arterial lumen. Okay, yes. Is it plantar fasciitis? A mediolateral squeezing happens in like calcaneal or stress fracture. Or and posterior tibial nerve entrapment, it is tarsal tunnel syndrome. And Achilles tendinopathy does not. Achilles tendinopathy does not cause this type of thing. Okay. So this patient with heel pain and is worse with weight bearing. This patient with heel pain and is worse with weight bearing has plantar fasciitis. Plantar fasciitis is common in obese, middle-aged adults, but it may also be seen in younger, well conditioned individuals who participate in high impact exercise and or spend extended periods in barefoot. Plantar fasciitis is characterized by inflammation and degeneration of the plantar aponeurosis. Inflammation and degeneration of the plantar aponeurosis, a thick fibrous band that extends from a thick fibrous band that extends from the calcaneus to the toe and supports the longitudinal arch of the foot. It is thought it is thought to be to be due to chronic overuse and repetitive microtrauma to the aponeurosis and its insertion point of the calcaneus. The diagnosis of the plantar fasciitis is based on clinical factors. The patient is often worse. The patient is often worse when first standing from the rest. It may lessen with activity and may again worsen after a long period of standing or walking. Physical examination typically shows tenderness at the insertion of the palmar fascia and the calcaneus, especially with the toe passively dorsiflexed. Especially with the toe passively dorsiflexed. When patients frequently does have pre-existing abnormalities of the arch base planus and high arch, X-ray may show calcification in the proximal plantar fascia heel spurs, but this finding is neither sensitive or not specific. And imaging is done primarily to rule out the other cause of pain. Initial management includes activity modification, avoiding walking barefoot, reducing high impact exercise, stretching exercise, and padded heel insert. However, the plantar aponeurosis recovers slowly. The long term outcome is generally good. but symptoms may require but symptoms may require most may require months or even years for complete resolution. Okay. Okay. Mm, This patient with pre-existing joint disease, previous pain, degenerative changes on X-ray, and immunocompromised diabetes mellitus now has acute pain, fever, and synovitis, erythema, warmth, swelling, finding concerning for septic arthritis. The diagnosis is further supported by joint aspiration, yielding cloudy synovial fluid, leukocytosis, and 95% polymorphonuclear cells. Although a positive gram stain would confirm the diagnosis, a negative gram stain, no bacteria, does not rule out infection. Only 30 to 50% sensitive. Initial treatment of septic arthritis include IV antibiotic, as with other purulent infection in closed spaces, immediate drainage of the purulent material, and irrigation to decrease the bacterial load. In most cases, drainage can be achieved in the operating room via arthroscopy, which uses small incision, a camera arthroscope, and a small caliber arthroscopic instrument rather than open arthrotomy. Serial procedure may be required to completely clear the infection. Yes, septic arthritis. Okay. Septic arthritis, advanced age, joint abnormality, osteoarthritis are a prosthesis or trauma, immunocompromised, diabetes mellitus, bacteremia, IV drug use, a clinical feature hot, swollen joint with a decreased range of motion, fever, and increased ESR and CRP. Synovial fluid analysis, leukocytosis more than 50,000 and gram stain, sensitivity 30 to 50%, and culture, blood culture. Initial treatment, IV antibiotic and joint irrigation and drainage, arthroscopy and open arthrotomy. So is it Dupuytren contracture? Okay. Okay, this patient has Dupuytren contracture at the base of the ring finger. Dupuytren contracture at the base of the ring finger. Dupuytren contracture is characterized by progressive fibrosis of the palmar fascia due to fibroblast proliferation and disorder collagen deposition. Although the etiology is unknown, risk factors include age more than 50, male sex, family history, Northern European ancestry. Manual work, gardening may also be a risk factor, and Dupuytren contracture occurs more commonly in patients with a history of tobacco and alcohol use and diabetes mellitus. Initial fascial fibrosis in painless puckering of the skin just proximal to the metacarpophalangeal joint. As fibrosis continues, pathognomonic fascial nodule along the flexure tendons and eventually progress to palpable fibrotic cord. Although patients may initially have full movement in their fingers, formation of these cords eventually results in contracture that lead to decreased extension and at the metacarpophalangeal and proximal interphalangeal joints. The ring and little finger are the most commonly involved, with the middle finger involved to a lesser extent. The diagnosis is made clinically, does not require imaging. Mild cases can also be managed with modification of hand tools, padded gloves, caution tape. Persistent or progressive disease may require needle disruption of the cord, aponeurotomy, or intralesional glucocorticoid surgery is occasionally required for advanced disease or contractures. Yes, calcific peritendinitis. Calcific peritendinitis is an inflammatory condition caused by calcium hydroxyapatite crystal deposition in the tendon. Flexure tenosynovitis. Flexure tenosynovitis is inflammation of the tendons and their synovial sheaths, typically caused by bacterial infection. Because of the inflammatory nature of both conditions, they present with pain, erythema, swelling, and features of DIC. Features absent in DIC. Okay. Okay, scoliosis. The lateral curvature of the spine is defined as curve angle more than 10 degrees. Scoliosis is most commonly idiopathic. Scoliosis is most commonly idiopathic in adolescent. However, pathologic cause, tumor, infection, trauma should be suspected in patient with scoliosis, and any of the following red flag feature: back pain, neurologic symptoms, rapidly progressive curve more than 10 degrees per year, and vertebral anomalies on X-ray. Although this patient has mild scoliosis and her symptoms are suggestive of underlying spinal pathology, back pain that causes nocturnal awakening, interferes with activity, and requires frequent analgesic, as in this patient. Concerning for spinal cord tumor, nerve impingement by the tumor can also result in weakness, dysesthesia, and incontinence. Infectious or traumatic cause may also be considered if fever and has an injury and or has a history of injury in this patient respectively. The first step in evaluation of scoliosis is posterior, anterior, and lateral spine X-ray. When pathologic, when pathologic etiology is suspected, MRI of the spine is typically diagnosed. Hello. In the Skype, it is clearly visible. Your screen is clearly visible, but in the Discord, it is slightly blurred. Maybe, maybe due to Discord has like other option. That's why, like Discord, there are some options you have to buy. That's why. Okay. No, no, no. You don't need to. Yes, sound, everything is better in Skype actually. Is it slipped capital femoral epiphysis? Oh, maybe it is wait, it is hip dislocation. No neurologic problem. Okay. It is PhD, posterior hip dislocation. So this patient has posterior hip dislocation. Posterior hip dislocation, which accounts for approximately 90% of the hip dislocation and is typically caused by an axial load on the femur while the hip is flexed and adducted. Dashboard injury. Patients have severe pain and difficulty walking. Patients have severe pain and difficulty walking. On examination, the hip is flexed, adducted, and internally rotated. Hip is flexed, adducted, and internally rotated. The limb often appears shortened. The limb often appears shortened. Plain X-ray is usually diagnostic, but both anteropostural and lateral views may be necessary to uh, differentiate a posterior from anterior dislocation. Due to violent nature of injury, hip dislocation is often associated with additional injury, including fracture that is acetabular, femoral, head, and sciatic nerve injury. Chronic complications include osteonecrosis of the femoral head. Osteonecrosis of the femoral head. Treatment of hip dislocation requires expedited reduction, typically within 6 hours of the injury. Dislocation without associated features and is usually managed with closed non-operative reduction in the emergency room, and dislocation with fracture warrants open reduction. Delayed reduction more than 6 hours is associated with increased risk of mm, what is this ONF? Oh, sorry. Delayed reduction more than 6 hours is associated with increased risk of osteonecrosis of the femoral head, and therefore discharging the patient or admitting without reduction is inappropriate. But fibromyalgia, muscle pain in the arms, shoulder that worsens acutely after exercise. Fibromyalgia improves after exercise, isn't it? It is not polymyalgia rheumatica because C-reactive protein is normal. ESR CRP is high in polymyalgia rheumatica. Yes, and six. Oh yes, he has classic point like low back pain radiating to buttock. Maybe it is ankylosing spondylitis, seronegative spondyloarthropathy because AS actually uh, or wait, you are right. You are right. No, you have it's fibromyalgia. Overthinking. Yes. Yes, in AS there is ESR CRP would be high. And age is 51. I missed the age. Age less than 45. Okay. This patient has a characteristic feature. This patient has characteristic feature of fibromyalgia. Fibromyalgia occurs most commonly in young to middle-aged women and presents with widespread pain, fatigue, and cognitive mood disturbance. Patients have a fairly normal physical examination except the trigger point tenderness in areas such as the mild trapezius, lateral epicondyle, and costochondral junction, and greater trochanter. Patients perceive their pain and fatigue. Patients perceive their pain and fatigue worsen acutely after exercise, although regular incremental low impact exercise regimen, fast walking, swimming, water aerobics can improve pain and provide long term benefit. The diagnosis of the fibromyalgia on is primarily based on history and examination findings. Revised 2010 American College of Rheumatology criteria suggest using the widespread pain index and symptom severity score for diagnosis, as these reflect the cognitive somatic symptom as this reflects the cognitive and somatic symptom of the disorder. A better than criteria based on trigger points, lab tests including inflammatory and serologic rheumatoid factor, antinuclear antibody markers are typically normal. Okay, yes. Fibromyalgia clinical feature: young to middle-aged woman, chronic widespread pain, fatigue, impaired concentration, and tenderness at the trigger point, mid-trapezius costochondral junction. More than 3 months with widespread pain index or symptom severity score and normal lab studies. Polymyositis, proximal muscle weakness increasing difficulty climbing stairs, and pain mild or absent. Elevated muscle enzyme CK, aldolase, AST, autoantibody, anti-Jo, ANA biopsy, endomysial infiltrate, patchy necrosis, polymyalgia rheumatica, age more than 50, systemic signs and symptoms, stiffness, more than pain in shoulders, hip, girdle, neck, association with giant cell arteries, elevated ESR, CRP, rapid improvement with glucocorticoid therapy. Okay, stiffness. Yes, he has done everything like physical therapy, steroid injection. So ultimately, surgery is the last option. This patient has chronic joint pain and stiffness consistent with chronic joint pain and stiffness consistent with osteoarthritis. The X-ray shows typical findings including narrowing of the joint space, periarticular osteophyte formation. Initial management of osteoarthritis of the knee includes non-pharmacological and lifestyle measures including weight loss, regular moderate activity, walking and exercise to strengthen the quadriceps muscle. Simple analgesic NSAIDs may also be helpful if conservative management is inadequate. Injectable glucocorticoid, possibly hyaluronic acid, may relieve some symptoms. However, appropriate measures have failed in this patient, so he is a candidate for surgical intervention with total knee arthroplasty, an elective surgery consisting of replacement of articular surface of the knee with prosthetic components. Total knee arthroplasty have been associated with significant improvement in pain level, function, and quality of care. Okay. Chronic treatment of osteoarthritis with long-acting opioid does not appear to provide substantial improvement in pain or function. It carries the significant risk. What's his problem? Oh, she's on hydralazine. Uh, so the mononitrate, but It's not GPA. Like I am thinking drug-induced SLE, hydralazine. I- 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 Is it possible? Okay, I have seen only the hydralazine, but okay. So it's confusing. Features are very confusing. It's not typical SLE feature. Okay, look at the box. Acute onset of constitutional symptom, fever, malaise, arthalgia, serositis, pleuritis, and pericarditis, and rash, less common compared with SLE. That's the thing. High drug dose, prolonged use for more than 3 months, and slow acetylator status. Confirmed by antihistone antibody and antinuclear antibody. An uh, most common procainamide, hydralazine, penicillamine, others like minocycline, TNF-alpha inhibitor, and isoniazid. Okay, okay. This patient has drug-induced SLE from hydralazine use. Drug-induced lupus, lupus can be diagnosed if at least one of the lupus criterion occurs after initiation of certain drugs, like fever, arthalgia, serositis, as seen in this patient with new pleuritic chest pain and pleuritic chest pain and pleural rub compared with SLE. A drug-induced lupus produce more abrupt symptom onset and is likely involve the skin and affects men and women of any age. Hydralazine often combined with nitrates for the treatment of heart failure. In angiotensin system inhibitor intolerant patient and is strongly linked to drug-induced lupus at frequency less than 20%. Other medication linked to drug-induced lupus include procainamide, minocycline, TNF-alpha inhibitor, isoniazid. Lupus-like symptoms may be related to autoantibodies induced by these drugs, anti-nuclear antibody, antihistone antibody. Patients' risk factor include prolonged use more than 3 months and slow acetylatory status. Treatment includes stopping the causative medication and treating symptoms. Non-NSAIDs. Okay, hypertrophic osteoarthropathy is a syndrome associated with underlying lung disease, adenocarcinoma, chronic pulmonary infection. Can cause arthalgia, however, it classically cause skin thickening and digital clubbering and history of chronic insidious symptom rather than acute pleuritis would be expected. And polyarticular gout can occur as a late complication of untreated gout or may manifest as symptom of myeloproliferative disorder. Often polyarticular gout can cause acute onset arthalgia, pleuritic chest pain, and inspiratory rub would not be likely. Okay, Okay. At full activation, the quadriceps muscle comprised at full activation the quadriceps muscle comprised of rectus femoris, vastus medialis, lateralis, and intermedius generates extreme force across the knee joint. Sudden forceful contraction as occur in deceleration from a fall and in certain athletic activity can cause rupture of the quadriceps patellar tendon complex. Tendon injuries can be diagnosed. Tendon injury can be categorized in relation to the patella. Quadriceps tendon tear proximal to the patella in rectus femoris. In the rectus femoris tendon, the patella right lobe, as seen in this patient, indicating patellar right lobe, indicating an contraction of the intact conduction to the tibia with a palpable defect above the patella and patellar tendon tear distal to the patella right high often with a palpable defect below the patella. The nomenclature can be confusing as the patellar tendon is actually a ligament. The patient who are on unable to bear weight after landing on the flexed knee and has a large knee effusion and a low lying patella. These presentations suggest quadriceps tendon rupture proximal to the patella. Typically, symptoms include an audible pop, rapid swelling, and inability to activity extend the knee against gravity. Risk factors include chronic kidney disease, hyperparathyroidism, and anabolic steroid abuse. Exposure to fluoroquinolone antibiotic may also increase the risk. The diagnosis and the extent of the injury can be assessed on MRI. Management of complete tears of the quadriceps tendon requires surgical intervention. Okay. Okay, it's plantar fasciitis. This patient with heel pain that is worse with weight bearing has plantar fasciitis. The plantar aponeurosis is a fibrous band that extends from the calcaneus to the toes and supports the longitudinal arch of the foot. Plantar fasciitis is characterized by inflammation and degeneration of the aponeurosis due to overuse and repetitive stress. It is common in middle-aged adult. It is common in middle-aged adults, especially those who are obese The patient is typically worst. The patient is typically worst during the first steps of the day, but gets better during the day and does not recur with normal activity. Pain also worsens after long periods of standing and walking. Examination in the plantar fasciitis shows tenderness at insertion. Tenderness at the insertion of the palmar fascia on the calcaneus, which is worse during positive dorsiflexion of the toe. Initial management include activity modification, avoidant walking barefoot, stretching, and padded heel insert. Symptoms may take months to completely resolve. Okay. X-ray in patients with plantar fasciitis may show calcification of the proximal fascia like heel spur, but this is neither sensitive or nor specific. Heel spur are late sign of inflammation and degeneration in the proximal plantar fascia, but are not the cause of pain. So heel spur are not the cause of pain, and Morton's neuroma is mechanically induced neuropathic degeneration of the interdigital nerve. It presents with numbness or pain at the distal forefoot between the third and fourth toe. The pain is often reproduced. The pain is often reproduced by squeezing the forefoot across the metatarsal, but is not aggravated by palpation between the yes. Next. It's maybe E. It's Schwarman kyphosis. Schwarman. Vertebra with anterior wedging. Schwarman kyphosis. Okay. This patient has back pain. This patient has back pain associated with kyphosis. associated with this patient has back pain associated with kyphosis. A hunched appearance due to excessive curvature of the spine, usually thoracic, leading to abnormal forward rounding of the back X-ray is a helpful component in the evaluation of kyphosis, particularly when specific features are present. In adolescent, kyphosis is typically due to slouching or poor posture. Postural kyphosis, it is not due to bony abnormality. The curvature is not rigid. The kyphosis corrects the supine and prone position. However, this patient's kyphosis does not correct, which is concerning for Schwarman kyphosis. Schwarman kyphosis is due to abnormal vertebral wedging with which creates abnormal vertebral wedging, which creates rigid curve in the spine. Patients commonly have pain that is worse with flexion, that is worse with flexion and after activity, and that improves with rest. That improves with rest. On examination, patients have hyperkyphosis of the thoracic spine and compensatory hyperlordosis of the lumbar spine. Diagnosis of Schwarman kyphosis require lateral spine X-ray demonstrating the kyphosis more than 40 degree and more than 5 degree of anterior wedging in 3 or more than 3 adjacent vertebrae. Treatment includes back strengthening and stretching exercise, avoidance of activity that incite pain, involve prolonged flexion. In addition, patients are monitored routinely during teenage years if kyphosis progress to more than 50 to 60 degrees. Okay. I think IBD. She is sexually active with a single partner. This patient likely has an IBD with inflammatory arthritis IBD, which includes Crohn's or ulcerative colitis, can demonstrate multiple extraintestinal manifestation, including arthritic, ocular, dermatologic, and hepatobiliary. Arthritis associated with IBD can involve axial or peripheral joints, and affected joints frequently have HLA-B27 genotype. Patients with axial involvement spondyloarthritis frequently have sacroiliitis that manifests with lower back and buttock pain and prolonged stiffness that improves with activity. There are no specific tests to confirm the diagnosis. Mm, to confirm the diagnosis of the IBD associated arthritis, but typical lab abnormalities elevated typical lab confirmatory include elevated inflammatory markers, C-reactive protein anemia of chronic disease, and positive fecal calprotectin, non-steroidal anti-inflammatory drugs can relieve arthritis. Symptoms may have exacerbate bowel inflammation and possibly due to disruption of the COX-mediated immunomodulation or inflammatory microcirculatory blood flow. Consequently, NSAID are often avoided, and the medication used to treat the GID manifestations of IBD as a azathioprine, infliximab are commonly used to treat associated joint disease as well. Okay, okay, okay.